for the part 2 of our parallel session, our presenters are the following. Dr. Ray Adam Cordoves of the Philippine Heart Center with the Research Association of AVR-ST elevation with outcomes in patients with acute coronary syndrome admitted at the tertiary hospital. Our second presenter is Dr. Emmanuel Raymundo of the Philippine Heart Center with the research, the use of the clinical frailty scale as a predictor of clinical outcomes of elderly patients undergoing open heart surgery. Our third presenter is Dr. Alex Gian Olfato of also from the Philippine Heart Center with the research correlation of CT epicardial fat, paracardial fat, and pericardial fat volumes with cardiovascular risk using Framingham risk scores. To our researchers, thank you for joining this forum and congratulations for reaching this stage. Okay, so we can begin with the presentation proper. Let me call on Dr. Ray Adam Cordoves of the Philippine Heart Center to present his paper on acute coronary syndrome.
Good afternoon, everyone. Once again, I'm Dr. Cordoves Ray Adam from the Philippine Heart Center. Today, I will be presenting my study entitled Associated AVR Outcomes in Coronary Syndrome Institution. Importance of a correct, complete interpretation of ECG in the diagnosis of acute coronary syndrome cannot overpass. However, BAVR or better likely ignored and considered just a reflection
Dr. Ray.
Dr.
Ray. Hello, sir. Sir, sorry to interrupt. Dr. Ray, sorry to interrupt.
Estimation of the AVR may be a significant predictor of a significant artery disease. But at this day, there's no single study that determines the clinical outcomes of acute coronary patients who presented with the lead AVR ST segment elevation admitted at the tertiary hospital. Hence, this study aimed to determine the association of an lead AVR ST elevation in patients with acute coronary syndrome with clinical outcomes and thereby help in risk stratification. For the methodology, this study is a retrospective cohort study which patients, all adult patients 19 years old and above with acute coronary syndrome with the following exclusion criteria. For the statistical analysis, this study uses independent sample t-test as well as Fisher's exact test to determine the difference of mean and frequency respectively. Odds ratio with the corresponding 95% confidence intervals for significant predictors of in-hospital outcomes with the primary outcome of in-hospital mortality.
Dr. Ray, hello.
Discussions. This is the distribution of patients according to the acute coronary fracture as well as the presence of a lead AVR ST elevation. Of 108 patients included in the study, mostly were males with a mean age of 58 years old with a body mass index of 24.9 to 25.2. About half of them were smokers, majority of them were hypertensives, and around 36% were diabetics. Most of these patients have an LV ejection fraction of 10% or more, with significant segmental wall motion abnormality in their 2D echocardiogram. Most of these patients have either a multivessel coronary artery disease or a left main involvement with corresponding in-hospital mortality, and majority of these patients underwent percutaneous coronary intervention. In terms of in-hospital mortality outcome, this set of patients who presented with in the emergency department with a lead AVR estimation has 7 times more likely to have an hospital mortality compared to those without. Upon coronary angiogram, these patients have either the significant left main coronary artery disease or a multi-vessel disease. Both studies done by Manuel Antonio, done in the Philippine Heart Center in the years 2003 and 2008 respectively, have shown that an ST elevation in the lead AVR is a significant predictor of a left coronary artery lesion among these patients. This is also illustrated in a study done by Wong et al. Last 2011 involving around 15,000 patients who presented with ST elevation in the lead AVR of 1 millimeter or more, which conferred at about 11.5% increase in the 30-day mortality admitted in the emergency department with presentation of anterior wall myocardial infarction. For my conclusion, patients who presented in the emergency department with acute coronary syndrome who presented with a lead AVR elevation carry a high mortality risks. Clinicians, cardiologists, as well as primary care physicians should be keen in looking for this particular ECG change, especially in the emergency setting. ST segment elevation, the lead AVR, should be included in the risk assessment and prognostication of acute coronary syndrome patients. Thank you.
Thank you very much, Dr. Cordoves of the Philippine Heart Center. Now we proceed to our second presenter, Dr. Emmanuel Raymundo, also from the Philippine Heart Center. Dr. Emmanuel, you have the floor po.
Hello, can you hear me po?
Yes, sir, we can hear you.
Can you see my slides?
Yes, sir, we can see your slides.
Okay. Good afternoon. I will be presenting my paper entitled The Use of the Clinical Frailty Scale as a Predictor of Clinical Outcomes of Elderly Patients Undergoing Open Heart Surgery. My name is Dr. Emmanuel P. Raymundo, and I'm from the Philippine Heart Center. Cardiac surgery has been associated with various post-operative complications, morbidities, and mortality. Thus, preoperative surgical risk assessment is paramount in determining the risks and benefits associated with these major operations. Various risk stratification models have been developed to assess these risks. Models such as the Society of Thoracic Surgeons Risk Model Calculator, European System for Cardiac Operative Risk Evaluation 2 or Euroscore 2 are currently being used internationally to compare the perioperative risk of morbidity and mortality of patients undergoing cardiac surgery. These models, however, are sometimes inaccurate in determining risk in some subsets of patients, such as elderly patients. These arise due to lack of assessment of the patient's functional status. Frailty has been defined as a syndrome of multiple facets of loss of reserves such as energy, health, physical ability, and cognition due to physical, psychological, and social factors, which lead to vulnerability. Frailty has been typically measured in various methods, such as rules-based definitions, which have defined rules. The presence of multiple symptoms will determine frailty, and itemizing and summary of multiple impairments has also been used. However, these scales are time-consuming and are not usually used widely. A third class of determining frailty has been the use of clinical judgment and parameters to interpret history and physical examinations in classifying patients to subsets of frailty. Scales such as the Clinical Frailty Scale or CFS. This method has been previously used to correlate prediction of death or need for institutional care. The results of these scales have been compared with other more established tools and have been found to perform better than other measures of cognition, function, or comorbidity in assessing risk for death. Here is an illustration of the clinical frailty scale as developed by Rockwood and the corresponding descriptions of each scale. For my study, my general objective is to determine the association of the clinical frailty scale to the outcomes of elderly patients undergoing open heart surgery. My specific objectives are to describe the clinical characteristics and the outcomes of elderly patients undergoing open heart surgery, to determine the clinical frailty scale scores of elderly patients undergoing open heart surgery, and to determine the association between clinical frailty scale scores and outcomes of elderly patients undergoing heart surgery. This was a prospective cohort study involving elderly patients who underwent open heart surgery at the Philippine Heart Center. Elderly patients aged 60 and above who underwent open heart surgery at the Philippine Heart Center from December 1, 2019 until June 30, 2020 were enrolled in this study. Patients who underwent any other concomitant procedure on the aorta were not included in the study. Institutional Review Board approval and informed consent of patients were obtained. Baseline preoperative patient characteristics were collected from the patient's history and workups. Patients were then stratified according to the clinical frailty scale criteria. This scale involves scores of increasing frailty from 1 very fit to 7 severely frail. Clinical frailty scale scores 8 and 9 were not included since these patients are at the end of life and thus were not candidates for surgery. The patients were then grouped according to CFS score into 3 groups of frailty. Scores 1 to 2 for those without significant frailty, scores 3 to 4 for those who are not active but still independent, and scores 5 to 7 for those with limitations in their activities. The primary clinical outcome for this study was in-hospital mortality. Secondary outcomes included were length of stay in the surgical intensive care unit, length of in-hospital stay, occurrence of morbidity such as prolonged inotropic support, resternotomy for bleeding, acute kidney injury, dialysis, post-operative atrial fibrillation, post-op site infection, type 5 myocardial infarction, stroke, use of intra-aortic balloon pump or IABP, or extracorporeal mechanical oxygenation or ECMO. A minimum of 57 patients were required for this study based on 3.95 odds ratio of patients with CFS score of 3 to 4 to predict in-hospital mortality, 5% level of significance, and 95% power. Descriptive statistics were used to summarize the demographic and clinical characteristics of the patients. Frequency and population were used for categorical variables, median and interquartile range for non-normal distributed continuous variables, and mean and standard deviation for normal distributed continuous variables. Furthermore, independent sample t-test, Mann-Whitney U-test, Fisher's exact test, one-way analysis of variance, Kruskal-Wallis test, chi-square test, odds ratio, two-tailed test, and Stata 13.1 were used. There were 57 patients that were included in the study. Of these, 15 had a CFS score of 1 to 2, 42 had CFS score of 3 to 4, and 0 had CFS score of 5 to 7. Patients were followed up until they were discharged from the hospital. Intraoperative data were gathered from operative technique records. These data are summarized in Table 1. Most of the preoperative demographic characteristics between the two groups are statistically insignificant, except for eGFR, Euroscore 2, STS score, and bypass time. Patients in the CFS class 3 to 4 group had lower eGFR, higher Euroscore 2 and STS scores, and longer bypass times as compared to patients in the class 1 to 2 group. The various outcomes occurring within each CFS group are summarized in Table 2. There were 3 mortalities during the study period, and all of these patients were in the 3 to 4 group. However, these were not statistically significant as compared to the class 1 to 2 group. Other clinical outcomes between the two groups were statistically similar, except for the hospital stay. Patients who had CFS scores of 3 to 4 had a significantly longer stay of 10 days as compared to patients who had CFS scores of 1 to 2, which were 7 days. A subgroup analysis of patients with CFS scores of 4 revealed a higher risk of specific outcomes after their surgical procedures. These patients were at higher risk of being on prolonged inotropic support, dialysis, and having atrial fibrillation. Table 3 summarizes the data on this subgroup. This study showed an association of the clinical Frailty scale to outcomes of elderly patients who underwent open heart surgery. It has demonstrated that preoperatively, patients with a higher CFS score had lower eGFR, higher Euroscore 2 STS scores, and longer bypass times. Postoperatively, patients with a higher CFS score had longer hospital stays. Patients having a CFS score of 4 were also more likely to be on prolonged inotropic support, dialysis, and have atrial fibrillation. The 3 deaths during the study period all had a CFS score of 4. Frail patients are more likely to experience higher risk of adverse outcomes due to an increased association with comorbidities and a decrease in physiologic reserve. A frail patient can have difficulties in maintaining homeostasis. In an event which can trigger a multisystem cascade of stress, the patient's physiologic response may lead to poor outcomes. During times of physiologic stressors such as surgery, a frail patient is exposed to increased vulnerabilities to mortality or morbidity. It is thus important to identify which patients are at an increased risk of developing postoperative complications. Preoperative risk assessment is important in determining outcomes after cardiac surgical procedures. Determining risk assessment helps clinicians in informing treatment decisions and prepare for any possible postoperative complications. The established risk stratification models such as Euroscore and STS score may over or underestimate the risks involved. These models take into account demographic and clinical factors, but do not include measurement of frailty, which is an important factor in the elderly. Tools to assess frailty have been developed and used to correlate prediction of mortality or morbidity in patients undergoing cardiac surgery. The clinical frailty scale was chosen for this study because this is an assessment tool based on clinical judgment, taking into account factors such as mobility, level of activity, and dependence of the patient during physical and cognitive activities. Unlike other frailty assessment tools, CFS assessment is a less cumbersome to use, less time-consuming, and inexpensive, and can easily be performed. The CFS has been compared with other more complex frailty assessment tools and was found to have a high correlation in terms of patient outcomes. The results of this study are consistent with other internationally published studies regarding the use of CFS and its correlation to patient outcomes in the elderly. They report similar outcomes, with the CFS being associated with preoperative comorbidities, length of stay, and complications. This study has shown statistically significant differences in the number of preoperative comorbidities, intraoperative results, and postoperative outcomes. However, this study was not able to show a statistically significant difference in terms of patient mortality. This may be due to a small sample size, which may not be able to generate a statistically significant difference in mortality between the two groups. This difference can be statistically significant in a bigger sample size, since all the mortalities are patients belonging to a single CFS group. The clinical Frailty scale model demonstrated an association to the outcomes of elderly patients who underwent open heart surgery. The model showed that patients with a higher CFS score had longer hospital stays and were more at risk to develop postoperative complications. The CFS model can thus be used as a preoperative risk assessment tool to stratify elderly patients who are at higher risk. The results in this study can be used as an adjunct for the inclusion of the clinical frailty scale in risk stratification models currently being used in the Philippine Heart Center. The CFS model is easy to use and less time-consuming. Thus, it will not add a significant load in the preoperative assessment of elderly patients. The model can also be used to operatively counsel patients regarding postoperative time of stay in the hospital. Furthermore, measures can be taken to mitigate the increased postoperative complication risk, such as prolonged inotropic support, dialysis, atrial fibrillation that are incurred by having a high CFS score. The study's small sample size may be a limitation to demonstrating statistical significance in some of the post-operative outcomes. Also, the subjective nature of the CFS model can be a limitation when being used by clinicians. Familiarity with how the tool is used is needed in order to have consistent reproducibility among clinicians. Further researches can recruit additional patients to increase sample size and can potentially demonstrate statistically significant differences. Also, further studies can focus on patients having a CFS score of 4 and elucidate which of the preoperative comorbidities and postoperative outcomes, especially mortality, the patients are at risk for. This is my last slide. Thank you very much.
Thank you po, Dr. Emmanuel from the Philippine Heart Center. Now let's proceed to our third presenter, Dr. Alex Gian Olfato, also from the Philippine Heart Center, with his research correlation of CT fat volumes with cardiovascular risk using the Framingham risk score.
Good afternoon to everyone. I am here to present my study entitled Correlation of CT Epicardial Fat, Paracardial Fat, and Pericardial Fat Volumes with Cardiovascular Risk using the Framingham risk score. I am Dr. Alex Gian B. Olfato II, and I am a former medical officer in the Philippine Heart Center. Cardiovascular disease has become a growing health concern worldwide. And based on a study of DOH, cardiovascular disease is now the leading cause of morbidity and mortality among Filipinos. In the advent of increasing role of diagnostic studies in today's practice of medicine, getting more information from them not only benefits us doctors, but ultimately our patients. In this regard, intrathoracic fat depots are not well studied, but are readily visualized in any CT scan involving the chest. But because of limited data about them, they are often overlooked and ignored. There are a few studies suggesting how epicardial and pericardial fat mediates obesity-related vascular disease. Studies about paracardial adipose tissue, however, are hard to come by. In a previous study done by the same author, epicardial adipose tissue thickness was noted to be moderately correlated with cardiovascular risk using Framingham risk score as a surrogate. However, several concerns have been raised against the use of thickness in like inter-observer variability and reproducibility. There is also a question if thickness can properly represent the total amount of fat pad. So in this present study, volume was used instead of thickness to quantify these fat depots. Like I said before, these fat depots are readily seen in any chest CT scan with no additional radiation or contrast exposure needed. So in this study would like to establish if epicardial adipose tissue, pericardial adipose tissue, and pericardial adipose tissue volumes are correlated with cardiovascular risk using Framingham risk score as a surrogate. It would also like to know if this intrathoracic fat depots could potentially serve as a additional marker or adjunct to already established cardiovascular markers. In this study, epicardial adipose tissue is defined as the fat contiguous with the myocardial surface between the epicardium and visceral pericardium. Paracardial adipose tissue, on the contrary, is the fat outside the parietal pericardium. Pericardial fat is simply the epicardial fat plus the paracardial fat. So the statement of the problem, so in adult Filipino patients aged 20 to 70 years old, the CT epicardial fat, paracardial fat, and pericardial fat volumes correlate with cardiovascular risk using the Framingham risk score. The objective of the study is to determine the correlation of epicardial fat, paracardial fat, and pericardial fat volumes with cardiovascular risk. For the methods, this is a cross-sectional study using data gathered from a previous study entitled The Correlation of CT Epicardial Adipose Tissue Thickness to Cardiovascular Risk using the Framingham Risk Score. CT scan studies of the subjects were retrieved. Using the smart segment function of the Philips IntelliSpace portal, epicardial adipose tissue, paracardial adipose tissue, and pericardial adipose tissue were manually seeded and volumes were derived. Framingham score was noted from a previous study. So initially, 10 subjects were randomly selected to be included in the pilot study. And after that, using STATA V13, a minimum of 20 patients were required for this study. There is 33 patients that is used for epicardial adipose tissue and 28 patients used for paracardial adipose tissue and pericardial adipose tissue. Correlation between these fat volumes with Framingham risk score were analyzed using person's product moment correlation. So this is just a diagram of how it was done. On the left is the manual seeding of the fat depots, and on the right side, you can see its volume rendering and volume derivation. For the results, after the study, there is note of moderate correlation of epicardial adipose tissue volume with Framingham risk score. There is also note of moderate correlation of the pericardial adipose tissue volume with Framingham risk score, while there is no significant correlation between the paracardial adipose tissue volume and the Framingham risk score. So like what I said earlier, there are few literatures suggesting that epicardial adipose tissue and pericardial adipose tissue are related to cardiovascular risk. So in a study done by Mancio J. et al., they concluded that epicardial adipose tissue is an independent predictor of non-calcified flow-limiting or vulnerable plaques in low to intermediate risk patient. In another study done by Mahabadi A. et al., epicardial fat is associated with fatal and non-fatal coronary events in the general population, independent of the traditional cardiovascular risk factors. He also added that epicardial fat volume complements information from cardiac CT above the coronary artery calcium score. For pericardial adipose tissue, Okura K. et al. Noted that it is a unique ectopic fat that may be more highly associated with ischemic heart disease progression. In another study done by Rosito G. et al., he presented theories and mechanisms in which epicardial adipose tissue may contribute to the increased cardiovascular risk. He noted that epicardial adipose tissue is associated with increased expression of inflammatory markers, including monocyte chemotactic protein 1, interleukin 6, and tumor necrosis factor. CD expression, which indicates activation of one or more inflammatory cell types, is higher in epicardial fat than in subcutaneous or omental fat depots. In addition, adiponectin expression is lower in epicardial fat depots. Well, adiponectin is a fat-derived hormone that appears to play a crucial role against insulin resistance, diabetes, and atherosclerosis. Thus, taking this into account, epicardial fat located in close proximity with the coronary arteries may have locally toxic effects on the vasculature. Other mechanisms cited in the study were probable direct influence in the perivascular inflammation and smooth muscle cell proliferation. In rat studies, in animal studies, it revealed that this may decrease vascular contractility, another example of a locally toxic effect. And also they noted it to be associated with insulin resistance. Other studies also done in China by Zhu J. et al., they noted that epicardial fat volume may increase or improve prediction of obstructive coronary artery disease above the traditional risk factors and coronary calcium score in the Chinese population. They cited the quantification of epicardial fat volume and coronary calcium score using non-contrast CT scan combined with age, sex, and chest pain characteristics provides the best estimation of pre-test probability of obstructive coronary artery disease. They also observed that this system also provided better risk stratification for diagnostic and treatment decision-making. In the study, they believe that epicardial adipose tissue is a biologically active organ that may contribute to atherosclerosis of coronary arteries through endocrine and paracrine pathway. In the end of that study, they concluded that epicardial fat volume may indeed complement coronary calcium score in the diagnosis of coronary artery disease, likely through a different mechanism such as lipid-rich plaque burden. So, in conclusion, this study demonstrated that epicardial adipose tissue and pericardial adipose tissue are moderately correlated with cardiovascular risk using Framingham risk score as a surrogate. In this regard, this may be possible promising markers in assessing cardiovascular risk in the future. They may also potentially add or complement to the other cardiovascular already proven cardiovascular markers. So for my recommendations, because this is a cross-sectional study, causality cannot be totally determined, and this study has a small population size. In this regard, a randomized controlled trial with a larger population is suggested to further establish the value of this intrathoracic fat depots. Also, a multidisciplinary study can be done involving long-term follow-ups and correlation with other proven cardiovascular markers. Further investigation may also be done if epicardial adipose tissue and pericardial adipose tissue volume can increase sensitivity or specificity of established markers such as CT calcium score and CT coronary angiography in assessing cardiovascular risk. And with that, I would like to say thank you.
Thank you. Thank you, Dr. Alex. And thank you to all our presenters for this session. So now we move on to our question and answer portion. To our guests and other participants, please type in your questions so Ma'am Joy can answer it. All right. Sige po. So, to remind yung ating mga participants who will give their questions, please type in first kung sino po yung presenter to answer, and then your question.
Dr. Gian, we have a question in the chat box. The question came from Ma'am Phoebe Kabab. The question is for the second presenter. How will this study provide faster or timely access for the treatment of heart patients?
Can you hear me?
Yes, doctor, we can hear you.
I'm also confused why I am put in the treatment and management portion. I think it's maybe on I maybe must be placed on the diagnostic category because I think this would serve as diagnostic procedures to probably know if the patient have increased cardiovascular risk. So I'm also confused why I'm in the treatment and management portion.
Right. Yes, sir. All of your presentations po are regarding diagnosis naman po. So,
Okay.
Yun lang po talaga yung title. Apologies for the confusion.
Okay, sorry.
Yes po.
Well, what I was trying to do in the I don't know. Can you repeat, ma'am, the question? How can it? Can you repeat the question, ma'am? Sorry.
I think let me rephrase it na lang, Ma'am Joy. How will your study? So it's okay. So na Dr. Alex, the third presenter, can answer this as well. How will the study, sir, provide timely access for actually to diagnose or to be part of the diagnosis of our heart patients? So those who have higher cardiovascular risk in your case.
Oh, can I answer? Okay. In heart center, when we are we have multiple patients who are asking for calcium coronary score or calcium or CT coronary angiography, and through that we can see if the patient has an increased risk for cardiovascular disease if there is a calcification in extensive calcification in the arteries, coronary arteries, or if there is blockage in the CT angiography. So in this study, we can also see the epicardial fat tissue around the heart. So I was thinking that because there is already this fat depots in present in this study, maybe we can make use of these fat depots to likely add on the information that we can get from CT coronary calcium score and CT coronary angiography.
I see. So, sir, let me see if I got it correctly, no? So, in your study, you have patients who underwent yung angiography na po talaga. So, invasive diagnostic test. And then, you are suggesting that we can also look at yung fat volumes when we do this angiography. Tama po ba, sir?
Parang like that, because the fat volumes are also included in the scan. Maybe we can use this fat volume as additional data, probably to risk to know the cardiovascular risk of the patient.
All right. Thank you, Dr. Alex. How about the second presenter, Dr. Emmanuel Raymundo? We have the same question po. So how will your study about yung clinical frailty scale help provide timely access for diagnosis of heart patient?
Okay, so for this study, the clinical frailty score is being used as a preoperative risk stratification tool. So in the study, it has been shown that patients belonging to a specific CFS score have a higher risk for certain morbidities, and even some the patients belonging to the CFS group 4 have a higher risk of mortality as well, because all the mortalities belong in this group. Although there needs to be a further study to elucidate this relationship. So for the future patients, we can use the CFS score as a preoperative tool, so that if we identify a patient belonging to a specific category or a group, we can preoperatively counsel them that they may have to stay longer in the hospital, because the study shows that patients in the CFS group 3 to 4 has a statistically longer stay in the hospital. And also we can counsel the patient that they are at higher risk for these specific morbidities. And also, um, intraoperatively, for the longer bypass time, we can prepare the patient itself, and possibly refer them to other specialties, or be prepared and watch and be on the lookout for the possible morbidities that the patient is at higher risk for. So, kumbaga, hindi tayo magugulat na bakit biglang nagkaroon ng gantong morbidities, because preoperatively, we have seen that this patient was belonging to this specific group, and thus it is at higher risk for this specific morbidity.
I see. Thank you, sir, for answering that question. Just curious question po, no? In the clinical frailty, I know you've showed this, but for those na hindi talaga cardio, no, sir? Does the clinical frailty scale use clinical diagnosis lang talaga, or do you have laboratory tests when you use this scale?
Really, as compared to the other, because yung nag-develop nitong clinical frailty scale is Dr. Rockwood. He developed a previous one, a frailty scale, which is actually more intensive. It consists of about 40 to 50 parameters, which includes laboratory values and other tests to be done by the patient. So in these studies, they see that it is very time consuming and cumbersome for the patients doing the preoperative testing and the risk stratification. So he developed a simpler risk stratification tool, this clinical frailty scale. Actually, this clinical frailty scale, um, based on the picture, actually, there's a questionnaire for this. It bases the scale of the patient based on the history and physical activity of the patient at home. So things like physical activity, exercise, um, activities of daily living like taking a bath, dressing up, going up from the bed, or paying bills. So they have a certain questionnaire, and based on the patient's answer to these questionnaires, they can be stratified to one of the nine categories of the patient. So it's faster and uh, less time consuming because it doesn't need to rely on laboratory results. Although, yun nga, it's a bit subjective because it depends on the questioner. But I think my experience on this is the categories are distinct enough from each other that you can differentiate from scales 1 to 9.
Right. Thank you for that clarification po, so Dr. Emmanuel. I think it's important because when you deal with elderly patients, usually the families do not consent to very how do I say invasive tests na ganun. So I think it's a very good consideration. I think we can also ask this question, itong how will your study provide or contribute to faster or timely diagnosis of acute coronary syndrome to our first presenter. So, Dr. Cordoves, can
Yes,
you,
Lauda.
yes po, can you
Actually,
give us, go ahead po.
oh, before, since nung fellowship pa, lead AVR is a neglected lead in the evaluation of the electrocardiogram. But up recently, there are several studies suggesting that it is a significant predictor of more morbid or more produces uh, more grave outcome among this set of patients. So this is very important since in our institution we are a referral institution. So we have patients coming from different primary hospitals or district hospitals with the evaluation of acute coronary syndrome. So from there, primary care physicians especially can better recognize this set of patients which confers higher mortality risk. So it is very important to really recognize these ECG changes among this set of patients. Thank you.
Wow, thank you, Doc Ray. Although may mga naputol kayong phrases, I think I got what you really wanted to say na this is applicable even for, tama po ba? Even for lower level facilities.
Yes po. It's more
Wow.
especially. Yes po.
I see. Go ahead po. May gusto pa kayong i-add?
Well, yun po. This is more really applicable sa level ng ng primary hospital po to better recognize this ECG change.
Nice. Thank you, Dr. Ray. So, I think many of our participants here kasi work with local health system. So we are very glad na may ganitong mga local researches to somehow improve na yung access natin to timely diagnosis, or at least improve yung process how we diagnose our patients. So we are engaged kasi with lower level facilities, not just tertiary. So it's important to look at the um, patient journey, kumbaga. So important yon. So thank you very much for your response, sir. So I think wala pang questions sa chat box, so I will continue asking questions to our presenters. Um, yes po, no? So For our third presenter, sir, just curious. So, how do you think, so can I just confirm, ano po yung naging um findings and recommendations nga po ulit dito sa research? Are you recommending to like look at it, some recommending for routine observation nitong fat volumes when you do angiograms?
Hello, rinig niyo po ako?
Yes po. Yes po.
Ah, ah, can you repeat the question, ma'am? Sorry.
Yes po. Sir, I would like to ask lang if is there recommendation po to like routinely look at fat volumes when you do um angiograms, or even kahit hindi nag-angiogram, you look at
Ah,
fat volumes, CT fat volumes?
ah, yung recommendation the recommendation of my study is to yung further evaluation, maybe on a larger trial, or maybe longer term follow up, kasi sa different countries meron silang mga may follow up studies, or they correlate it with other cardiovascular markers. But when you say na routinely use it, kasi what my study is CT scan, so may burden may burden ng radiation. So what I am suggesting is maybe for studies like calcium CT score, or maybe CT coronary artery angiogram, where makikita rin naman siya, maybe this could be used as additional source of data. Pero using this routinely for that only, maybe uh, hindi siya advisable, kasi may may burden ng radiation. Initially kasi the study was used for epicardial adipose tissue thickness, and it is used sa 2D echo yata nila ginamit. So yung kasi wala kasing radiation doon. So maybe that's where nanggaling yung study ko.
Okay, thank you very much, Doc. Sige po. So, so regarding cost nito, sir, so ang recommendation naman, what do you think about, will this improve cost, or parang hindi medyo costly itong additional indicators po?
Regarding the cost, wala ka ng additional cost, kasi when you acquire the images, nandun na rin siya. Nandun na rin yung fat volume na yon. So kasi kunwari sa CT calcium score, or CT coronary angio, ang ina-evaluate lang natin yung arteries. Pero when acquiring the images, kasama na talaga yung fat volume. Minsan napuputol, pero madalas kasama it's also included there. So additional cost parang wala. Though wala pa kasi hindi pa kasi already proven yung fat depots as intrathoracic fat depots as cardiovascular risk markers. Yun lang.
Okay. Thank you, sir. Congratulations po to our dear colleagues for their well-made research papers. Ito naman for the diagnosis of patients. So kanina, treatment. I hope that we can continue to encourage other clinicians po to endeavor these local researches that can positively influence our clinical practice guidelines, and eventually yung larger health system, our policies, and even laws. So just a quick review of what we've learned. So we've in this part 2, session 5, we heard about researches regarding diagnosis of our patients. So a paper, acute coronary syndromes. We have a paper looking at clinical frailty scale to assess our elderly patients undergoing open heart surgery. We have a paper looking into the CT epicardial fat, paracardial fat, and pericardial fat volumes to analyze the cardiovascular risk of these patients. So this session reinforced my learnings din po, no? From the part 1 session. So kanina po, we've discussed treatment eh. So ngayon, diagnosis naman. So let me just highlight them, especially for new attendees in this session. So first, it is important to encourage evidence generation that is tailored fit for our population. So importante po itong local researches. So majority of our practice guidelines po are based on literature about Western people. So it might not be applicable in our population. We might have unique characteristics. So it's important to even review evidence. So we've seen it sa pagtingin ng AVR-ST elevation, and it's applicable pala to Filipinos. Clinical frailty scale, it's applicable then, and even exploring yung fat volumes. Second, we need researches that are designed to improve yung actual process natin of diagnosis. So meaning applicable siya sa local health system. So we've heard a study that can be applicable not just in tertiary hospitals but also in our lower level facilities. So completing yung ating patient journey. It's important that we have designed this researches to improve our policies so we can direct our health facility investments po toward that. So, and of course, improve yung patient outcomes and access. So, kunyari, yung our elderly patients na usually the families do not consent invasive tests, we have alternatives as well. So, that's the second point. And third, just like in our first session, it's very important to disseminate the findings of these local researches to spark interest and discussion as we all aim to improve our health system. So it's important that others are made aware of the researches, the findings, and that these learnings do not just remain within our institution. So hopefully, yung pag-establish ng network ay mag-push through so that things like yung our first presenter mentioned, that AVR-ST elevation can be actually applied dun sa ibang applicable health facilities. So that's it for my synthesis.